Hey there, future certified coders. Welcome back. I am just beyond thrilled to have you here today. Look, before we even jump into today's high-yield material, you gotta do me a quick favor. Make sure to like, share, and subscribe to Decode Healthcare with Harshal. Trust me, you absolutely do not want to miss what we've got coming up. Because, guys, just like that, we hit a massive milestone. Welcome to Part 50. Yeah, we're officially at the halfway point in our 100-part CPC exam series. So just take a second, give yourself a pat on the back, and celebrate your hard work. Really mastering these concepts, passing this exam, it's going to completely transform your career. Let's get into it. Okay, so here's our roadmap for today. We're looking at hospital inpatient and observation, the emergency department, critical care services, consultations, nursing facilities, and then wrapping it all up with a master cheat sheet. All right, let's kick things off with Section 1, Hospital Inpatient and Observation Care. So under the current EM guidelines, inpatient and observation services, they actually share the exact same code set. So imagine your patient, let's just call him Mr. Smith, is just admitted, right? Your main job is to figure out if it's initial care, which falls in the 99221 to 99223 range. But, when the provider goes in to check on him the very next day, well, that shifts to subsequent care, and that puts you right into the 99231 to 99233 range. It's really that simple. Now, for same-day admission and discharge, there's a strict rule. The criteria absolutely require a minimum 8-hour stay. If Mr. Smith is feeling better and he bounces at, say, hour 7, there is no way you can use those same-day codes. Auditors will catch that in a heartbeat. And for standard discharge, you've really got to watch the clock. Code 99238 is for 30 minutes or less, while 99239 requires detailed documentation of greater than 30 minutes. Literally every single minute counts in your provider's documentation here. Moving right along to Section 2, the emergency department. Okay, listen up, because here is a golden rule and a massive audit trap. Time cannot be used as a descriptive factor for code selection in the ED. Why? Well, think about it. The emergency department is just inherently chaotic. It's totally unpredictable. A patient might be sitting in a bed for 10 hours waiting for lab results, but the provider really only spent maybe 15 minutes actually with them. Because of that chaos, code levels here are strictly driven by medical decision-making, or MDM, never, ever time. Oh, and also, keep in mind that patient status distinctions, new versus established, those completely disappear in the ED setting. All right, let's dive into Section 3, critical care services. So, imagine our patient's condition takes a turn for the worse. By definition, critical care is the direct delivery of medical care for a critically ill or injured patient who's dealing with vital organ system failure. Now, this one is entirely time-based, and let me tell you, the thresholds are totally unforgiving. Say a provider spends 29 agonizing minutes saving a patient's life, you still cannot bill critical care. Nope. You have to use a standard E&M code instead. The clock officially starts for code 99291 at exactly 30 minutes, and that covers you up to 74 minutes. After that, every additional 30 minutes earns you the add-on code 99292. But hey, watch out for unbundling. Certain services are just inherently included in these critical care codes, so if you see radiologic interpretations, blood gases, chest x-rays, vascular access, or gastric intubation performed during critical care, do not code them separately. They're bundled right in. Unbundling those is basically a fast track to audit failures and some pretty severe financial penalties for your practice. Always double check your documentation. Okay, Section 4, consultations. Let's say a specialist gets called in to evaluate our patient. To absolutely ace any consultation questions, you just need to remember the 3 R's mnemonic. First up, request. There has to be a request from another qualified provider. Second, reason. The reason for the consult has to be clearly documented. And third, report. There must be a written report sent back to that requesting provider. If even one of those R's is missing, it's not a consult. But knowing the 3 R's isn't quite enough. You really have to know who's actually paying the bill. See, commercial payers generally accept standard CPT consultation codes. Medicare, though, they flat out reject them. So for Medicare, you have to report the appropriate outpatient or inpatient E/M code instead, and then you're going to append modifier AI to identify the principal physician. Missing this little distinction is going to guarantee a claim denial for sure. Section 5, nursing facility. So eventually, our patient might get discharged to a lower level of care.
Kind of like in the hospital setting, your documentation has to clearly differentiate between initial nursing facility visits, and those use codes 99304 to 99306, and subsequent visits, which use codes 99307 to 99310. And pay really special attention to comprehensive annual assessments, because they have some very specific reporting requirements in this category that you will definitely see pop up on the exam.
And finally, Section 6, our master cheat sheet. All right, this visual summary right here recaps all those golden rules we just dissected. You're going to want to lock these into your memory. The emergency department is MDM only, never time. Critical care requires at least 30 minutes on the dot. Consults need those 3 Rs. And inpatient has officially merged with observation. Honestly, knowing these core drivers inside and out is basically your secret weapon for the CPC exam. Phew, you made it through Part 50. But hey, we are just getting warmed up here. Get ready for Part 51, where we're going to do a CPC exam practice masterclass packed with high-yield, real-world E&M case studies. Before you go, definitely hit that subscribe button, and I want to leave you with one final thought to chew on. How confident are you really in spotting that ED time trap on a real exam scenario? Think about it, study hard, and I will see you in the next explainer.